Alzheimer's and Dementia, Basics and Beyond, Part 1, presented by Alzheimer's Association, Minnesota, North Dakota. 24/7 information hotline, 1-800-272-3900.
So I'm guessing most of you have some sort of connection to Alzheimer's disease, dementia, or a related disorder. Is that a fair statement? Now we're going to see how smart you are. These are true and false questions, and can you see if I stand here? Okay. So having a little touch of dementia is normal. What do you think about that? Not normal at all. If I have memory loss, it means that I have Alzheimer's disease or dementia. Yeah, it better not, because we probably all have it, right? Yeah, we're going to talk a little bit about things that are associated with age or age-related memory loss, as opposed to something that would be possibly problematic. If Alzheimer's disease runs in your family, genetic testing is something that you should do, because then it's going to tell you whether or not you're going to get it. No. Ooh, smart group. There's two exceptions to that. There's two particular types of Alzheimer's disease, so in case you thought there was only one, there's more than one. But there are two particular types that we do have a genetic test for, having to do with two specific types of proteins. One for what we know to be called younger onset, so people that are diagnosed with this disease before the age of 65, and one that we would consider to be more typical after the age of 75. And both types of this disease in this particular case are familial. And when I say familial, I don't mean just a parent or a grandparent. I mean that plus multiple siblings in one particular family unit and multiple extended family. So this is not just my mom has a diagnosis or my grandmother had a diagnosis. This is the disease that would be heavily embedded. And in terms of numbers, we're talking less than 1% of the diagnosed population. So it's a very small number. There's no point in getting a diagnosis because you can't do anything about it. No. False. Now we're going to talk a little bit about in terms of what you can do for the disease versus what you can do for your quality of life. And from the Alzheimer's Association's perspective, we really talk more about quality of life. And you can prevent this disease. You can lower your risk, but you cannot prevent this disease. So there are things called modifiable risk factors: high blood pressure, diabetes, controlling diet, staying physically active. All of those things are good. But right now, I cannot in this room say to you, if you do any of those things, you will prevent yourself from getting the disease, because none of that has any evidence to support it at this point. So let's talk about our problems with memory, shall we? Particularly as we get a little bit older, somehow I had this delusion that as we got older, things got easier and less complicated. And I've discovered that that's not quite the case. In fact, sometimes things get more complicated, multiple steps, multiple things going on. So it's not uncommon that you might make a bad decision or a bad choice. And you realize it after the fact, but you don't realize it proactively. You might miss a payment. Particularly if you have a lot going on in your life, these sorts of things, even though they're quite routine, can be missed. How many of you have ever gone on vacation and forgot what day it is? Yeah, and isn't that why we go on vacation? The problem would come if you're not able to reorient yourself. So if you're not able to come back, when you come back from vacation and you realize, oh, I have to go back to work on Monday, because you don't realize it's going to be Monday. But yes, please forget what day it is when you go on vacation. Forgetting which word to use. Frequently, and I don't know if you know this, but the thing people fear the most is public speaking. Standing up in front of a group of people and speaking. So for some of you, if I sat down and made you stand here, you would rather be in the hospital or in some tragic situation, because people get very nervous sometimes and forget they can't figure out the right word. They know what they want to say, but the word doesn't come out. And this is something that happens to a lot of us. It's also remembering names, remembering people's names. By the way, what's mine? Oh, very good. So you only heard that once. Now, for some people, you're not name people. You're not paying attention to it, and it's not a pass-fail kind of thing, so don't worry. But sometimes forgetting those kinds of things. Using written notes. Have any of you taken a note yet? Do any of you have Post-it notes at your desk or where you work? Yeah, those are called memory aids, and we all use them. How we ever survived without Post-it notes is nothing short of a miracle, because we use them all the time. We color code them. There's big ones, there's little ones, there's ones that really stick. But
String doesn't do the trick anymore?
No. I mean, if you like that, feel free.
All right.
But my whole hand would be covered with string. It would not be very fashionable. Losing things, if you've ever misplaced your keys. The difference between you and I is if we misplace our keys or we forget, I think the next one talks about where you parked your car, we're usually able to recover from that. We remember when we find the keys, we know what they're for. A person that has dementia is going to find the keys, know that they're keys, but not know what they're for because they don't remember that they lost them in the first place. Or you had alluded to paranoia. It's the person that misplaces their wallet or their purse, and you find it. Isn't that nice? And you're now going to give it back to them. And instead of them saying thank you, they say, why did you steal my purse? Because they don't remember that they lost it. So when is it a problem? Speaking of Post-it notes, and that's not the problem. Because you all work for the Department of Health and Human Services, I'm letting you in on a secret. We talk a lot about dementia, and I want to make you aware that dementia is now going to be called something else. We're not sure when that's going to hit the mainstream, but it's coming. So instead of dementia, you may hear something called mild or major neurocognitive disorders. Now, for the purposes of today's little discussion, we're still calling it dementia, but I wanted to put that out there because you're going to see it, and I don't know if when it comes up it's going to be explained. So I just want you to file that, so know that that's essentially what we know as dementia. Dementia is a general term. True or false, dementia and Alzheimer's disease are the same thing. Yeah, they are not synonymous. Although a lot of people in the public believe that to be the case, and they will use them interchangeably. Dementia is the symptom. Just like if someone had a diagnosis of cancer, you would then want to know what type. Dementia is no different. What type of dementia? Alzheimer's is the most common. We see about 70% of people having dementia have Alzheimer's type, but there is a whole list of others that we don't really have time to talk about today. But I did give you some examples, what we call mixed dementia, where you sort of buy one, get one free. You may have Parkinson's disease, and then you may have a vascular dementia. So you may have two different types because there's two different conditions that are aggravating that symptom. You may have Alzheimer's disease, and then you may develop Parkinson's disease. So you may have two that way. Vascular dementia, just so you understand, would be the stroke, the heart attack, where any kind of oxygen flow to the brain is somehow depleted. You've probably heard of something called mild cognitive impairment, or MCI. We're seeing this more often. We know this to be a risk factor for Alzheimer's disease, but we don't know it to be a certainty for Alzheimer's disease. One thing that's interesting about mild cognitive impairment is that the person that has MCI is far more likely to notice it than you are. So we can test for it, we know that it's there, but the people are very highly functional. So unless they tell you, you may never know that they have this.
Under that new category, autism spectrum disorders will not fall.
Nope. No, this is just the new jargon in the new DSM for dementia. But I anticipate that clinicians are going to start using it. So I just want you to be ready that if you hear that, that's what they're referring to dementia. So all types of dementia include these things. The biggest one is recent memory. Excuse me. And this is typically, when we talk about the 10 warning signs of Alzheimer's disease in particular, we talk about short-term memory loss. That is usually the thing that people pick up on soonest. So this is the repetitive questions. And I don't mean just a couple of repetitive questions. I mean many, many, many repetitive questions in a very short period of time. These are also the individuals that eat breakfast. They walk out of the dining room, or they walk out of the restaurant or the kitchen, and they come up to you and they say, I'm hungry, can you give me something to eat? Because in that 10 seconds that they've left that space, they don't remember that they've eaten. So it's significant short-term memory impairment that impairs their ability to function. Language, trouble identifying objects. They will call things the wrong name. So for example, If I was looking for these things that some of you are wearing in the room and they go here and I see better when I have those, I'm guessing you would all know that I'm talking about glasses. But for the person with dementia, that word may not come out. They may be able to describe an object's function but not provide the name. Visual images and spatial relationships, this is driving. Thinking about, and I almost had a head-on collision in the parking lot of my office building this morning because somebody was driving down one row of parking and I was coming in the driveway and they weren't looking. And when there's weather involved and you have to seriously think about the space and how much longer it may take you to stop, if I had dementia, I probably would have had an accident because the ability to judge space. Sitting is another thing we notice. Excuse me, with chairs that don't have arms. You're very dependent on the arms of a chair to help you judge your space. When you try to sit in a chair without arms, especially if that chair has wheels, if any of you have a desk chair that has no arms and wheels, you've got a risk there if you also would have dementia because it's very hard to judge, plus the seat is moving. So that's kind of an example. Loss of executive function, checkbooks, paying bills, anything to do with numbers or that higher level function. With Alzheimer's disease, we get some extra things. We get difficulty completing tasks. Most of you this morning had a particular routine that you followed when you got up. Most of us do the same things in the same order every day, whether we think about it or not. It's just what happens. And most of us are able to complete those tasks with really you don't have to hyperanalyze. You don't have to think about each task. I want you to think about one of those tasks for a little bit, and that would be brushing your teeth. And I want you to think for a minute about how complex that one task is, and you don't even think about it. And for example, think about this. In a typical bathroom, there are 3 places you can get water. How do you know which is the right place? And when you identify which is the correct one, how do you turn it on? Because it doesn't automatically do that. Even those motion-censored water faucets, unless you have your hand in the right place, don't turn on. And then what if you want hot or cold? How do you know how to do that? You and I don't think about that. Someone with dementia starts having significant difficulty with these types of tasks. Misplacing things but not able to retrace steps. You and I might lose something. We think about where did I have it last, who was with me, what did I use it for, and usually we find it. Or if we forget to do something, we're going to remember at 3 o'clock in the morning when that thought wakes us up. The person with dementia is going to lose the memory altogether. So if they go to a movie on yesterday and you're going to ask them about that movie today, they're likely not even going to remember that they went to a movie, let alone what the name of the movie was. So they'll lose the event completely. Decreased or poor judgment. So in Minnesota in December, apparently, what would that be?
No coat.
No coat, improper shoes, no gloves, all that kind of stuff. Withdrawal from work or social activities, and this is beyond what would be typical. We all have days where we want to be alone, where we don't want to be bothered. This is somebody who's historically very extroverted, very engaged, and now they don't want to do anything. And the same with changes in mood and personality. This is beyond a bad day. So Alzheimer's disease is a disease. It is a clinical condition. It is a diagnosable condition that causes significant damage to the brain cells. Brain cells are currently not something that we can regenerate. So once they're gone, they're gone. And we have no evidence-based prevention right now. There are things, you can even buy a book called the Alzheimer's Prevention Project, or the Alzheimer's Prevention Plan, written by a doctor, MD, out at UCLA. In the very first page of the book, in the preface, it states right there that what you're really preventing is a higher risk. So you're modifying those risk factors, which unless you read that, and how many people read the preface to a book, you're not going to pick up. We don't know how to fix this. We don't know how to cure it. We don't have any effective treatment other than symptomatic. We can treat the symptoms. There's drugs that have been FDA approved to treat the symptoms, but it doesn't fix the disease. And I need you to understand that of the big diseases, so when we talk about heart disease, cancer, HIV, AIDS, all of those conditions have drugs that can actually impact the course of the disease. In some cases ahead of time, in some cases during, and then in some cases, certain types of cancer, there's drugs you can take after to help you lower your risk to develop a recurrence. We have nothing like this with Alzheimer's disease. The problem with that scenario is that we are getting older, we are living longer, and the greatest risk for this disease is age. So for the first time ever, and there's actually an event tomorrow here in St. Paul at the Wilder Foundation that is the kickoff event for Alzheimer's disease being designated as a public health crisis. And the disease has been around over 100 years. So it's about time. And ultimately, this disease is, of course, fatal. Why do we talk about early diagnosis? Well, because the sooner you know what you're dealing with, the better. We can also tell you what you're not dealing with. When we talk about the different types of dementia, a lot of them have very specific diagnostic processes that we go through to diagnose those conditions. Alzheimer's disease, we used to tell you, even as recent as 5 years ago, I would have said we can't diagnose until somebody dies and we do an autopsy of brain tissue. Now I can tell you that we diagnose about 95% accurately pre-death. To get a definitive diagnosis, the autopsy is still true, but we pretty much know what we're dealing with 95% of the time. So those are pretty good odds as far as I'm concerned. MRI is a part of it. A PET scan can be a part of it. CAT scan, CT with contrast. We also do pretty in-depth neuropsychological testing. Because Alzheimer's has some unique features, if you think back to the slide where all types of dementia have some, but then Alzheimer's has some unique, those are some of the things that we test. So being able to complete tasks. There's one series of cognitive tests, for example, that a person has to use a phone book to call a hardware store to buy paint. And so it's being able to follow all of those steps, and can they do that successfully? Can they dial the phone? Another part of the test is to make a sandwich. What's interesting about this, and one of a kind of a cute story that I've heard, is you can, if you don't need any cues to perform the particular task, so you can make the sandwich just by looking at the supplies, then yay for you, that's no cognitive impairment. Then depending on the level of cueing or how much cueing, then that changes your score over time. So in one testing situation, the tester said to the person that was being tested, why don't you put the peanut butter on the bread? You know what they did? They took the jar of peanut butter and put the jar of peanut butter on the bread. Now, in reality, they did what they were told. However, they didn't get the piece about, oh, I should have opened it and I should have taken some peanut butter out of the jar first. So it's those types of tests. It's a very grueling process for the patient. It's about 4 to 6 hours long, but that's how we know. And so it's the testing piece. So we want to rule out other health problems. Clearly, dementia can look like other things. People that have chronic depression, they can seem like they have dementia. They can have problems with short-term memory loss with depression. They can be socially isolated with depression. So you want to know what it isn't. They could have a cardiac problem. They could have had a small stroke. So it's important to do all of those tests so when they get evaluated, they're getting a very good history and physical, all sorts of labs to check really what it is and what it isn't, and if there's any other underlying medical conditions. We talk a lot, too, about education. You should have seen a postcard in the back about a conference that we do here in the spring at the River Center, and I believe the front of it says something like, knowledge is power. We really talk a lot to people, both that are caregivers as well as people living with the disease, that the more you know, the better able you will be to live with the disease. We are also concerned, though, about knowing the right information. So we try very hard to make sure we have a presence because there is a lot of information out there that's not correct, and we want people to know what is correct. Ability to plan. This is a huge piece of what we do, not only for the person living with the disease, but the caregiver. Planning. I will assume, for purposes of this discussion, that all of you in this room have done your powers of attorney. You have done your health care directives. Everybody that needs those copies has them, and all is well. If you have not done that, shame on you. You work for an organization that has the word health in it. this is something that you need to do before you need it, because then you're not going to have to think about it when the time comes for you to need it. And you want to be able to have a voice. We talk a lot about getting people engaged and being involved in making healthcare decisions. Here's a huge opportunity for you to do that while you have time. And in case you're concerned that it takes a lot of time, both of those documents you can get online for free. One of them only requires witnesses and the other only requires a notary. So you don't even have to do it through an attorney. You can, but it can be as simple as printing out the 3-page short form power of attorney and having it signed and notarized. So it's really something to think about.
Do you have that site available?
Off the top of my head, I would just type in Minnesota Power of Attorney. But don't pay for it. You can get them for free. So there's lots of opportunities and resources for that, but really take advantage of planning while you don't have a reason to have to plan. And if your parents haven't done it, if your parents are still around, I know my mother is a retired nurse, and they didn't do this until about 9 years ago when I threatened them. Because it was really important for me that they made those decisions. I would do whatever they wanted, but I just wanted it down on a piece of paper. So just a little bit about statistics, and this document is available on our website if you want the whole document. There's also on our website, you can get Minnesota-specific information if you're so inclined. We currently have 5 million people, a little over 5 million people in the country with this disease. Those of you that follow facts and figures at all are going to think that there's been a decline since we did this in 2012, and that's actually true in terms of this report. A year ago, I would have said 5.4 million. The actual number is 5.2 now, 200,000 of them being under the age of 65. What I think is happening personally, and I have no evidence to support this, just my opinion, is that first ring of baby boomers turned 65 in 2011. I think we've hit a little bit of a plateau until those folks start to age a little bit and we see some of those numbers going up in what we anticipate will be exponential numbers. By 2050, we estimate somewhere around 16 million in the United States having Alzheimer's disease. 1 in 3 seniors this year will die from Alzheimer's disease or a related dementia, which is about 450,000. And yet, we don't talk about this disease with any sort of consistency. I will share with you that in August, my husband was diagnosed with cancer. My entire office knows it. Our friends and family know it. It's no big deal to talk about cancer because most of us probably know somebody, if we haven't been affected ourselves or somebody that we love, and we talk about it all the time. Now, in 1950, we said, the neighbor's got cancer. We didn't say it out loud. We didn't share that information. We have the same problem now with Alzheimer's disease and dementia. We're not talking about it. There's a huge stigma associated with this disease. People living with the disease are embarrassed because people don't understand it, nor do they take the time to understand it. So it's important to realize that this is not going to go away. It's only going to get worse before it gets better. And in Minnesota, we currently have about 100,000 individuals in the state living with this disease. And I would challenge you to think about how many do you know? You know, it's that whole 6 degrees of separation thing. Who do you know already? You know, do you have work colleagues that are caregiving that you don't know about? Do you have a work colleague that has the disease? Do you have neighbors, friends, family that are not talking about it because they don't want to or they're ashamed? We need to get Alzheimer's disease in the vernacular as much as cancer is. Just like HIV and AIDS, you know, that was just the gay community for a while until it suddenly wasn't. And then it changes. No, I totally understand what you mean. And in terms of healthcare professionals not knowing, you're exactly right. There are certain types of healthcare professionals that think they know, but they don't. Any of you physicians? Okay, then I can talk about Dr. Bob. Dr. Bob is the family doctor. You know, that tends to be where most of us are going to go. If we're not feeling well, we go see Dr. Bob. Because Dr. Bob, you've been seeing that same doctor, chances are, or with any luck, for a number of years. It's not their area of expertise. And depending on where you live, that's an added challenge because you may not have access to a neurologist, a geriatrician, or a neuropsychologist that can actually do the diagnosis. One of the things, you may have heard of something called Act on Alzheimer's, and that's a conversation for another day, but it's a statewide initiative to really take a look at preparing Minnesota for Alzheimer's disease by 2020 so that we actually know what to do with people that live in our state that are dealing with this diagnosis. And a piece of that is helping physicians be able to readily identify. Medicare in January of this year started a wellness visit, and as a part of that wellness visit, they need to do a cognitive screen. We're trying to teach providers, because those are the general practitioners that are doing that, how to use these cognitive tools, but also what to do if somebody doesn't do well. It's not a pass-fail kind of tool, or if you don't do well, it means this, but it means there might be a red flag that needs further assessment, and get them out of that practitioner's office and into somebody's office that has that area of expertise. But you are absolutely correct. I'm not a clinician, but what I will tell you with medications is this. You want to take a look at what medications are needed in terms of maintaining things that impact quality of life. Blood pressure medications or things that control pain. But when you get into certain kinds of pain medication, you can get some really nasty side effects from pain medication. Some of the drugs that we use to treat Alzheimer's disease, Aricept as an example, can have significant side effects for people that are not able to tolerate it. And it's not unique. I mean, there's a lot of drugs that will have side effects depending on the person's chemistry. But Aricept can cause nausea, vomiting, diarrhea, can cause hallucinations, can cause cardiac problems. So it's that risk-benefit analysis when you start getting in the land of drugs where what's going to happen if they're not on it? What's the worst case scenario? And really taking a hard look at that kind of stuff. Because some of those drugs are nasty. And I do want to comment too, you know, you said your comment was about cancer having a plan, or however, I forget exactly, a path. For the record, no, it doesn't. And from the caregiver side, you know, it's been an interesting journey. I've learned a lot about being a caregiver and how lousy I am at it, frankly. But there is no book out there on how to be a caregiver that tells you everything you need to know that's not in all the other books. You know, they give you a manual how to live with your diagnosis of cancer, and it doesn't have any of the answers to the questions you need. Because like dementia, the disease is so unique to the individual and everybody's path is so unique that even though there's sort of, here's the beginning and ultimately it's fatal, you know, depending on the type of cancer obviously, but certainly with Alzheimer's disease it's fatal, but that path is so varied either way. So I don't think there is, that's just my personal sidebar. No. Didn't say that for you to have to apologize. Just, I think in context, it's been a very interesting learning curve for me to learn about all the things you have to learn to be a caregiver because they don't tell you. And even though they give you a book of what it's supposed to be like, it's not going to be like that. All of those, you know, geriatrician, gerontologist, neuropsychologist, but somebody that if the universe were a perfect place, that is absolutely what I would recommend. We are nowhere near being able to do that. And the test he probably did is something we call a mini mental status exam, which has 30 questions, and on any given day, any one of us in this room could fail that test or be classified as having dementia based on how we score. When my husband, he was in the hospital in October, and to get discharged, he had to pass an MMSE, that's what we call it. And one of the questions, how many of you are really good at math? Okay, without a calculator. So if I were to ask you, so you start with the number 100 and you have to subtract by 7. So most of us get to 93, no sweat. And then it's like, okay, I need you know, and I carry the 1 and cross. For some people, they can't do that, and especially under pressure, people do really poorly on those kinds of tests. So it was a picture of a point in time with your mom, but hard to know if it would have been, in fact, representative of a more global diagnosis because that's all they did. And this is what we're trying to have doctors not do. We're actually trying to not use that particular screening tool anymore. There's 2 others that are much more efficient, that give a much better indication. And what they indicate is the need for further assessment. They're not a diagnostic tool, they're a screen. So it's just like if you go get your cholesterol screened at Cub Foods and your cholesterol happens to be high that day, does not mean that you have high cholesterol. It means that you probably should have it checked out because for some reason you were really high that day.